Yes, good afternoon. I'm here with Dr. Yaffe, and so today we're focusing on long-term care, as we should be because of all the issues that are going on there. We have some other comments and other data and information points as well, and to get a sense overall how we're endeavoring to undertake the next 2-week period, working at our at-risk sites, as in some long-term care facilities, retirement homes, and other congregate settings, as we seek to continue to bend the curve and to, in the future, get some more updates to the modelers to give us another report card sometime in the future. But right now, we want to continue the good progress we've made and work at the areas where we have to put even more energy into. And I know the Premier's talked about that, and we're going to be talking about that also today. So first, over to the numbers overall with Dr. Yaffe.
Okay, thanks very much. So in the IFIS data, input by public health units as of 4 p.m. yesterday, we have a total of 12,245 confirmed cases of COVID-19 in Ontario, which represents an increase of 510 cases from the previous report. Of these, almost 57% are in females, 44% are in people 60 years of age and older, and 59.3% are people who live in the Greater Toronto Area. We have a total of 659 deaths, unfortunately, which is an increase of 37 deaths from the previous report. 51% of cases, or 6,221, have been resolved. We have 12% of cases, or almost 1,500, are in healthcare workers. And this is a cumulative number. It's not necessarily those who are currently positive. 878 cases are currently hospitalized. Of those, 243 are in ICU, and of those, 192 are on a ventilator. In terms of the laboratory testing, 184,531 people have been tested in Ontario. Currently, 6,845 are under investigation, and in the last 24 hours, 10,361 tests have been completed. In terms of long-term care, as I've indicated previously, there are different databases used to collect the details related to outbreaks in long-term care facilities, and each of the databases has its strengths and weaknesses. So I'm going to use the numbers that have been provided to us by the Ministry of Long-Term Care as of 3:30 p.m. yesterday. We have a total of 127 homes with outbreaks, and that includes 1,985 cases in residents, 957 cases in staff, with 447 deaths in residents and 1 death in a staff person. As you know, the ministry has been very closely monitoring the impact of COVID-19 in the province's long-term care homes, and part of the COVID-19 action plan for protecting long-term care homes, the command table has taken action to increase testing in these homes. And this includes immediately testing all the residents and staff in homes that are in outbreak or where staff or residents have exhibited symptoms, as well as beginning surveillance testing in homes that have no symptomatic residents or staff. We have asked each public health unit to immediately begin developing a local implementation plan in coordination with the Ontario Health Region and the Ministry of Long-Term Care Region to facilitate testing every resident and staff at every long-term care home. Public health units have been asked to prioritize homes with what we call a red status, the most urgent need, those currently in outbreak. And they are using their clinical judgment to help identify additional information to help prioritize additional testing, drawing on local supports to increase capacity to support this important initiative. And in addition, there will be daily reviews and updates to the risk assessments completed for each long-term care home in the province from both a public health and an operational perspective to ensure that homes have the supports they need when they need it. So I'll turn it back to Dr. Williams now.
Well, thank you. And so in that, we see that the number of tests is up. to our over 10,000, heading towards our new capacity of 13,000, and we are looking at even going beyond that if we can. So this has given us more opportunity to do even further testing, and as Dr. Yaffe has alluded to, we did send out a memo because we have ramped up even further our testing in our long-term care facilities in that regard, so that we can prioritize those ones that are in the so-called red zone. That's the scoring combined with public health and with the Ministry of Long-Term Care, and then looking at those most in need, especially ones in the midst of outbreaks and ones with more extensive outbreaks. As you heard from the Premier today, announced even further steps. We have a special incident command group led by Dr. Smith, and looking at how we might move resources from a number of sectors into the long-term care homes, those that are in a very high outbreak position where they're being their capacity is being highly compromised due to staff shortages, etc. And so to utilize hospital resources, to utilize other staff and qualified staff and volunteers, and we've also asked, with the federal government's cooperation, to use Canadian Armed Forces medical personnel and teams to come in. And as the Premier said, we're looking at potentially 5 teams that might be assigned to 5 locations. Those are to be determined, but haven't been finalized yet, that could move alongside to assist those homes, because when we see they come into, they may have one case, they can handle that. When they get into a number of cases and a number of staff become positive, then a large part of the staff are then put in isolation, and they lose their capacity to give all the adequate care and services, and those remaining are then put in long hours, many continuous days, and we know that that can't be sustained. Therefore, they need to bring in other resources and assess that, as the team will do, whether it's assessing human health resources, assessing further testing, assessing whether there's a further need for personal protective equipment, and as well as other infection prevention control methods to deal with it, including moving patients, etc., to bring it under control and to decrease the mortality, for certainly, and morbidity if and where possible. So that's been a large advancement there, and one that we're, and I'm most eager to see take effect and to have an impact in this area of need at this time. And then we have to look beyond that. Would we have to do that in some other settings in the future? And we're looking in that regard. The testing, as I said, is up. A lot of it is due to the amount of extra testing already started prior to the memo going out, and that's why you can see there's about 450 of the positive tests in the long-term care report are from staff and residents in those facilities. So that testing is already ramping up. Even the assessment centers, because remember, we already had, before this one, we'd asked our health units to do even wider testing than they did before, beyond just the positive case to the other asymptomatic people around there. And we asked the assessment centers to test people of the public with even mild symptoms, and those are the wider range of symptoms that have deemed to be compatible with COVID-19. And their numbers were up considerably, because the ones that we're seeing today, included in this, reached a new high of assessments we haven't seen for a while, with over 5,800 being seen in assessment centers and over 4,700 tests being done. That's on the Monday after a weekend, which is usually after the dip, and so we'll see if that is one level that's going to be sustained in that regard. So we're getting more testing all around as we seek to, one, deal with the aspect of the long-term care outbreak, which, as our modeler said, is one curve, and the other one with our ongoing assessment of the public, with more testing being done with more and more people with milder symptoms to ascertain if we indeed are at a plateau, and if we're indeed going to start heading down or not in that. The other thing that's encouraging as our testing goes on is that our positivity rate has been coming down from a high at the peak of almost like the beginning of April, around about 12.5%, nearly 13%. We're now down to just over 7%. So that, in some ways, for our epidemiologists, is even a more encouraging sense of the waning of the impact at this moment of the COVID-19. But we still have a way to go. We still have to get our numbers down, and we still have to get back to where we were when we had containment with our case contact management, which was a while back, when our numbers daily were in the upper, just under 100, just over 100, and we started going above 200. And when we did that, we started seeing more community transmission, and we weren't able to do the intense contact tracing we'd hoped for. So we're hoping to get back to that level before we can ascertain and give to our public health measures enough advice to the minister and to the premier of when they can ascertain when to start to look at some recovery modes in there and when the timing for that is correct. So we have a number of steps to go through, and we're giving our advice in that direction. And of course, we're reporting to the public once we have those decisions made in that framework agreed upon by the minister and by the premier and by the cabinet in that regard. So those are our numbers. And again, it's critical that we stay in the aspect of being at home, keep the 6-foot distancing. All those other steps are very important. Those that feel they might be in a compromised situation, you can wear a facial covering, a mask, cloth mask if you may, and we continue to ramp up and roll out our PPE to our various sectors. And we're also having our health units, if there are congregate settings that have outbreaks, to investigate those thoroughly, including testing all the residents and staff of those places, if that is what the medical officer of health locally feels they need to do to assess the situation accurately. So more intense testing, more intense monitoring, more intense intervention, and keep up the intensity with the social distancing and the other aspects there as we look to identify in the next 2 weeks where we at as our ability to not only flatten the curve in the community side and maybe start to bring it down, and we're hoping for that. And then on the other side, can we start to bend the curve on the long-term care issue? So both are very important and critical at this time. So with that, I'm going to hand things over for questions.
Okay, we'll go to the phone lines.
Your first question comes from Cynthia Mulligan with City News. Please go ahead.
Hello, Dr. Williams. Today, the Premier expressed a lot of frustration that things weren't happening as quickly as he wants, and you've taken a lot of criticism for not acting fast enough on long-term care issues. It seems to me the Premier threw you under the bus today. What is your response to that?
I think the frustration, if the Premier has, is the same as I've had. At different times, we would like to really ramp up a lot more testing, a lot more things quicker. We were limited first by reagents and by swabs. We had some limitations with PPE. We still have some difficulty getting there and moving out on that area in all the different fronts. So I would think it's just that the Premier is definitely wants to get this moving, wants to get it over with, would like to decrease the deaths as quickly as possible, knowing still that the modelers said we have really done well and have brought down that and flattened the curve in that regard. Our mortality rates are less than some other centers, definitely, and so we've been successful. Are we satisfied with that? The Premier's not satisfied, and I'm not satisfied. I'd like to drive it down even further, as we all would. And so there's no time for complacency here. So, no, I don't see it in that sense there. And, of course, my advice goes to the Premier. And the fact that he's standing up and making his strong commitment to this, as he needs to be done, is only but appropriate for the Premier. And so, again, I give him the best advice I can. But we need the power and authority of the Minister, as well as the Ministry and the Premier, to back up those with resources and materials so we can get on and get the task done. And in a way, it's a call for all hands on deck. And so I applaud the Premier for making that stance. And as you said, he takes the responsibility. And we want to support him in that way. And, of course, the public of Ontario.
Follow-up?
Thank you. And my follow-up is, yesterday you were talking about how you'd like to see community spread cases drop to at least under 200 a day. Yesterday, I believe we were around 400 a day. Can you give us the mathematical breakdown today of the new cases of what is community spread versus long-term care?
So I said yesterday I'd like to see our daily numbers of positives in the community to drop below 200, not the community spread. I was concerned that when we went above 200, a number of our cases that didn't have travel history, didn't have contact history, and had no definite history as they picked up in the community and unsure how they got it, so-called community spread, started increasing. As we got up to around 300, we went up closer to 50% of those ones there. Our travel ones have been eliminated. So I'd like to see us back down that range because it gets us closer to where we can start to consider driving down even lower to make sure that we're back into the case contact containment type modality. That's very critical if we're going to try and get our so-called R naught number down even lower below 1 that we could then say we are convinced that now we have a certain level of safety in the public, a certain level of low transmission of the virus in the public that we can control either through case contact management or in clusters, that we could start to look at easing off some of the public health measures. So in that sense, like today, you saw that yesterday we only had about 74 cases in with 600 positives. 74 were supposedly in long-term care. We knew it was more than that. It's because the data coming in through the Yaffe system and through the administrative data today, of the 550, nearly 475 are from long-term care. I don't believe that means only about 80 are left in the community. I do think it's a data flow issue there. So I'm still thinking we're probably in the 400 range daily in the community level. So we have a way to go. I think we can get there. I think it'll come down. But when I say the 200, I want to be well below the 200, because it's around the 200 where we started losing the ability to do all the case containment and started going to a lot more community spread.
Next question.
Your next question comes from Laura Stone with the Globe and Mail. Please go ahead.
Hi, Dr. Williams. I just want to pick up on your comments about resources. So you say you give advice to the minister and it's up to them to back up with resources. So has Ontario not had enough resources to do aggressive testing in long-term care homes?
When we start out in this one, remember, we could only do about 900 tests a day. And we increased that up to around 1,800. We had the need for more testing equipment. We had the need for more, and with the testing equipment, more reagents, and with the more testing, the more swabs. They have all been with a group working at this very hard, getting the number of laboratories expanded to well over 13 or 14, and we now have community labs as well. So our capacity can continue to grow, maybe not as fast as we'd like it to, but they were trying to make sure they had the reagents and swabs and all the equipment there, because it's no use rolling up a high number of tests, one, if they're not consistent, if they're not very sensitive and specific. We want to make sure the quality of the testing is good. The reporting is done in a timely way. They have to have continuous supply of reagents and swabs to do that. So there's a number of things that go into that. If we had a number of things way back earlier, we could have been much more liberal with our testing, but that was the reality that we and other jurisdictions, I can say that's true all across Canada, were facing those limitations, and still are, in some extent, of their ability to just do unlimited testing. And that's part of the reality that we faced in the public health sector, our sector faced, our deputy and our team, our command table, the minister and the premier. And everybody's worked diligently at their own level to push and ask and get all those resources back up, so that we're in a situation today where we're looking at doing 13,000 and maybe going up to 15 and beyond. So we're a lot better positioned than we were before in that. But that was part of the reality of dealing with a global pandemic where everybody's competing for the same resources at the same time. And whatever you have, you make the best of it, and you do what you need to do to bring things under control and seek to bend the curve.
Follow up.
And just on some of your own advice, I wonder why you have been cautious on testing guidelines for outbreaks in long-term care. For instance, we saw in the memo released yesterday that only now is Ontario broadening testing to everyone in a home with an outbreak. I think a lot of people would be shocked to know that wasn't happening. And also on the widespread testing of every resident and staff member in a home. I mean, we've been asking you this for weeks now, and yourself and Dr. Yaffe have essentially said it's wasteful to test everyone. So can you explain those two policies and why you have changed your position on them?
So when we had originally, remember our outbreak definition is that when you have a case identified with signs and symptoms compatible with COVID-19, you do the test on that person. If they're positive, and you identify another person, you had an outbreak. And that was our traditional outbreak management in long-term care facilities, like we do with influenza. Then we sat back that off and said, well, if you have a person who is one case, you can call it an outbreak. And then we found that it seems to be not as sensitive enough, because some people are saying, well, there may be some that are transmitting and you don't see it because some of the elderly people don't show all the symptoms right away. So then we said, well, let's back it off and make it even more sensitive. And this is all being developed by COVID-19 as we understand the epidemiology better and better. So then we backed it off to saying anyone who's symptomatic with anything, call it an outbreak, not only test that person, And we went to the other step, which even some of our other provinces and territories have not done. We said we're going to test asymptomatic residents around that person and staff who had contact with that person. So that was our first foray into testing asymptomatic people, because you remember the advice from the WHO and from Health Canada and from the rest of the provinces and territories that we should only be testing people who are symptomatic. The evidence was that asymptomatic people were not highly transmittable in that sense. So we're following the advice and direction of all the rest. In that time now, we said, well, because we continue to see this escalating, maybe we should do some further ones. So we did do a survey, and some of the health units did do some studies. We looked at long-term care facility wide, and found that there were some staff and some of the residents who, as far as they were determined by the long-term care facility, were asymptomatic, and they were positive. So this provoked the fact that our command team said, I think in that case we're going to have to start testing everybody. And so the direction was not that you heard the memo, was not that we do testing of everybody in an outbreak. We already were doing that. We now can test even where there is no outbreak. That was the direction of the memo last night. So we see some of our facilities that have so-called red status, even though you have no cases and no outbreak, we hope to be able to test those as well, to persuade ourselves, are we missing cases or are we not missing cases where there's been no evidence of any cases as far as the institution is concerned, just to make sure we're not missing it and we have to expand our surveillance even further. So we're one of the few jurisdictions in Canada that are doing widespread asymptomatic testing at this time, and we hope to be informed by that and get better information as we do that, now that we have the lab capacity to undertake that.
Next question.
Your next question comes from Mike Crawley with CBC News. Please go ahead.
Hi, Dr. Williams. I'm going to try a similar question to what Laura just asked you. It seemed that for weeks the message from you was recommending against the idea of testing everyone in long-term care homes. So I'm trying to understand what your reasoning was for that. Was it about the lack of testing resources? Was it about the advice you had that testing asymptomatic people was a waste of time? Again, just take me back a few weeks when we were asking you why not test everyone in the long-term care homes. Up until now, you've been saying not to do that. What was your thinking in recommending against that?
So there's about three parts there. One was when you asked that 2 weeks ago, our capacity then was around about 5,000 to 6,000 tests a day. We were pretty well at that. We had just come down off of our backlog, which was deemed to be a critical issue because we were not moving our tests through in a efficient way, and some of our high priority ones that we were wanting to make sure we could turn them around in 24 to 48 hours, we were being slowed down in that regard. And those still are top priority ones to turn those around fairly quickly. Healthcare workers, those in special settings, as well as new outbreak cases, etc., and other at-risk vulnerable populations. So that's still there. So we couldn't really go at that time. At the same time, our evidence and science said that then it's only transmissions from symptomatic patients. And the question we were asked ourselves, were the staff symptomatic or not? Were the residents symptomatic? And we widened our surveillance around that because our outbreaks then, is even back on the 8th of April, when we looked at our data, a lot of our positive cases were not from long-term care homes, even though they were doing the testing, and we hadn't seen the going up the curve or the slope of the large impacts and outbreaks, because with our public health measures, you have to understand a test by itself doesn't really achieve much. A test is to drive you forward for further action. The key to controlling an outbreak in a long-term care facility is a combination of, one, personal protective equipment, second, infection prevention control practices, as in cleaning and sanitizing and moving people around and separating, and other things with cohort nursing, etc. All those things will do more, the testing won't do. The test just tells you how you work it and how you operate in that setting. So to go about and do wide testing, especially in areas that you have no outbreaks, it means some of the other priority ones you may not get to investigate and carry out those actions. So you have to understand the value of testing, what's its use, and on its own, it doesn't do much unless it drives your policy and directions towards further actions. So at that time, we didn't have a lot of outbreaks, it seemed, which is different than the rest of the countries like Italy, where their facilities with elderly people at the same time had the same high rate of cases as the general public, and their system, their hospital system, was overwhelmed. Ours is actually delayed by 2 or 3 weeks, as the modelers have said. It's a different delayed curve. So we had some effect of slowing its input. What is challenging to us is that with our limitations on visitors, with our screen of the staff, how did it get into the long-term care facilities? And then we see some cases where they have one case, it doesn't seem to be going anywhere.
Already 40 dead and in nursing and retirement homes, and at least 41 facilities that had outbreaks in them. Given that, was the screening that was being done in March in long-term care homes inadequate?
So what we were mostly trying to address there is that was the screening was one aspect. We do some more tests in that regard. Was the delivery and supply of PPE in all those facilities up and adequately? Was the training of the staff completed? And in our survey we've done with all the long-term care facilities, we found there is a spectrum. There's some that were well prepared, the green category. Some had some intermittent problems, the yellow, and some of the red, where they haven't had a lot of that aspect there. So we still have a lot of work to do with ramping up the other measures, as in the education, the infection prevention control practices, the PPE, as well as movements by the Ministry of Long-Term Care to decrease the like the rooms where there's 4 in a room down to 3 or 2, preferably 2, and then to have more spacing out in that regard. So all those things had to be addressed at that time. So they're all ramping up as we felt that the issue with the hospital side, the community side, with the rising numbers before that time going into our hospitals, going into our ICUs, where there was a concern that we might overtax the acute care sector, where these patients could be referred to if needed from long-term care. And as that system seemed to be plateauing, we could put even more emphasis onto long-term care. But then the main front was on the general population, trying to stem. What we saw is the modeling direction was very draconian type of results if we did not work aggressively at that and continue to put our resources into the wider group first, and then moving over to other priority areas.
Next question, unfortunately, this will be our last question.
Your final question comes from Rob Ferguson with the Toronto Star. Please go ahead.
Hi, doctors. Just wondering, Doug Ford was musing today about when school might come back. So how does school fit in to what you're saying about getting the number of new cases down to 100 to 200 a day? Do you think we'll see kids back in school this year? Will you recommend that if we get to a certain level, and what level would that be?
Well, I'm going to let Dr. Yaffe comment on some of the stuff we talked about earlier, getting some studies from our federal counterparts on children, their contribution to COVID-19 thus far. And so we did receive some stuff, so maybe Dr. Yaffe would want to talk about that first, and I'll comment later how that fits into school discussions.
Sure, thank you. Public Health Agency of Canada has done a review of the cases to date, and a very small percentage of cases are in children under 18. In fact, and as they get younger, even lower percentage. And they've also done a review of the studies that have been done to date. And not only is it not common to get an infection in that age group, and there could be a number of reasons for that, but they're also very rarely the source of infection for others in the household. Usually there are others who have given it to them, in fact. So those are promising findings in terms of children, but again, there are just a few studies, and it's early information. Some of those studies haven't even been published yet, so I'll turn it back to Dr. Williams.
And Rob, we've had discussions at the federal, provincial, territorial level, each one asking, are you going to open up schools? When are you going to open up schools? One of the key factors there is that we first wanted to be driven by the data that Dr. Yaffe has spoken about. Are children a vehicle of transmission? Often with flu season they are, and some other infections such as measles and different areas, they certainly are a vector for transmission. The data would indicate that they're not. They can be, of course, seen in some of the studies that if you have a family who's positive, the adults, they can actually carry it for a little bit from the parents in there. So therefore the key is the parents, as in the public in general, are they at a low enough transmission rate or positivity rate that you would be persuaded that no child is just going to come into the classroom and start to carry it around? The reassurance is it doesn't seem to be that really transmittable from child to child. So we're going to be weighing that evidence as we go forward. But if we had still widespread community transmission, we're going to be leery to do that. And I think some parents would be leery to do that, knowing that they may reintroduce it back in again. So let's see how we're going to do over the next number of weeks. In there, we're going to be working with, in consultation with the Ministry of Education, with the minister, and with the deputy, and giving advice in that regard, and discussing things with our counterparts across the country of what are you going to do with school openings, how are you going to do it, can you do it the same way as it was before, what ways you're going to mitigate any transmission and the distances if possible. These are all things that are on the table that are still may seem early, but you need to have these discussions now, and so we're having lots of those informed discussions and planning taking place at this time.
Okay, we'll do a follow-up, and this is the last question.
Yeah, thank you for that answer. Just a different follow-up on this. These teams of Army medics or people from Public Health Canada that you'd like to get to the nursing homes, how many bodies are you talking about? How many people would be in these teams? What would they be comprised of?
So I guess I could give an example of a team size. There's about 5 teams. We understand from the Canadian Armed Forces that they're headed up usually by they're medical personnel, headed up by an officer, usually is a nurse, and under them they have like MedCorps staff who are trained in medical and can do all those functions and duties under that leadership of the officer. And then they have some other general medical or general military personnel who can be used for tasks as assigned by the officer in charge. Each one has a composition, I hear, about 50 or so, so you can see that 5 times about 250 is about the number. So each one of the units is going to be about that size. I don't think it's exact. So we're going to have to wait to see how that rolls out, and in discussion with the Canadian Armed Forces and the federal government as they come forward, and see how we're going to utilize that that resource, which is great to have, and how that works with our whole structure that's dealing with the long-term under Dr. Smith and the team that's looking at that, which is going to build alongside with hospital resources and other resources too. So it's not the only venue. They're trying to put, again, as we talked before, all hands on deck to see if we can move into all those facilities that are either in a major outbreak situation or could be teetering on one to defuse it as quick as possible. So that's the plan and hope at this time.
Okay, thanks everyone.